Hey everyone, and welcome back to my channel. I'm so happy that you have tuned in to join me and many other pre-PAs and currently PASs around the world for another end of rotation review. Now, I just got through doing an internal medicine rotation, which was inpatient, and that just meant that I followed the doctor around the hospital, and we made rounds and we saw all his patients that was previously admitted, and we make sure that we're doing the best we can to follow their illnesses, make sure that they're recovering, doing better, taking the proper next steps, etc. So on this rotation, I was in a little small town in South Carolina called King Street at Williamsburg Regional Hospital. And let me tell you guys, it was definitely something to get used to. The hospital was very small. It was affected by one of the hurricanes that came through previously, and it is doing the best it can to thrive. The doctor who I was with, I can't say his name, but he was very opinionated, as most are, and very confrontational, but he was a great teacher. I learned a lot, and I have oodles and noodles of clinical pearls to share with you all in a second here. But overall, I had a good rotation. I was ready for it to end because I was very tired of driving and making that 1 hour drive every day, getting up at 5 o'clock to be there at 8, and I'm slow in the morning, and sometimes you don't get breakfast, etc., etc. And this rotation was exactly a world of difference from my family medicine rotation, because there I did everything. I saw patients on my own. I was seeing patients before the doctor even came in for the day. I did everything but re-prescribe their medicine. I even, I present the patient. It was more like we were working together as a team, even though I was a student. At this rotation, it was more like I was shadowing, and they were scared to let me do anything, and they didn't bother to find out what I knew and what I didn't know, and it's kind of like they really didn't give me a chance at all. But I got over it, and towards the end, I guess I kind of grew on them and whatnot, but it wasn't the ideal rotation. It was nothing like my first one. My first one set the standard real high, and I was expecting every other doctor to be on the same page, every other location, and that definitely wasn't the case. But it's okay, because you live and you learn, and I'm here for the experience. So with all that being said, let's jump into some clinical pearls that I've learned that I would like to share with all of you on clinical rotation, or soon to be on clinical rotation. That is great pearls. So if you have something to write with, pause this video and get it. So lo and behold, I forgot my medical bag. I'm at school right now, as you can see, and I'm preparing for my end of rotation exam tomorrow, which is 9 o'clock, bright and early. And I left my journal, which I kept with me throughout rotations, and I write down my little clinical notes and clinical pearls that I was so eager to share with you guys. So give me 24 hours. I will finish recording this video tomorrow, and finish up with the clinical pearls and my upcoming videos, so to speak, and let you guys know what I'm thinking about implementing into my little series while I'm taking you guys along on this journey with me. Thank you for being so patient. Thank you for tuning in. Thank you for supporting me, and I will see you all in almost about 24 hours. Okay everyone, and we're back. It's 24 hours later. I just got through eating lunch, and this morning I just got through taking my end of rotation exam. Happy that it's over, but let's just jump right into this. So some clinical pearls that I got while I was on internal inpatient medicine. So when you see white blood cells bottom out on labs or get extremely low on labs from being high previously, my doctor said that this is a sign of sepsis. Pearl number 2, you can use Zyvox for MRSA for low renal failure instead of vancomycin. You can give dobutamine and Lexiscan to do a nuclear stress test. A crescendo decrescendo angina. Used to walk 3 blocks. Now before I can walk 1, I get angina. Unstable angina is the earliest onset of heart conditions, MI, etc. is the main one that we're worried about. And they could have a normal chest x-ray, but and EKG labs and everything could be negative too, but you want to admit and monitor that patient because they eventually could be going for a PCI. Microanemia, you have low hemoglobin and hematocrit, high MCV, and low retic count. CBC and TSH with multiple myeloma. Folate is low, B12 is low. So those are the labs you kind of want to run when you're worried about microanemia. And some of the things you might see, low folate and low B12, which are causes of macrocytic anemia. And you could possibly see jowl bodies, jowl hollow bodies. Microcytic anemia, you have low hemoglobin and hematocrit, low MCV but high retic count. And you would order a CBC, a ferritin, a transferrin serum, iron, and occult. So you would do that, kind of like get a CBC with diff and do a IBC panel. Let's see. Elavil is the most cardiotoxic tricyclic antidepressant. Never, ever, ever, and this might be common sense, but we've seen so many of this here, never put a person with asthma on a beta blocker. Okay, never put a person with asthma on a beta blocker because they will wheeze and cough and be miserable. There are many other medications that you can use. We have learned that ACE and beta blocker and conditions can improve mortality, morbidity rates, whatever, but don't put them on a beta blocker. Sometimes you have to use quality of life over, making good clinical choices. So just keep that in mind. Okay, hold on guys, because I'm trying to talk and read everything in my little book that I showed y'all before, so hold on. Statins can cause, myalgia is the #1 side effect of statins, and it can cause back pain. So you can hold the medicine. One of the things you can do is to pinpoint if statins are the cause. You can hold the statin, and then if the back pain goes away, of course we know that that was the cause. Okay, so my next one, if you get a person with a tremor that goes away after they drink alcohol, that's a benign essential tremor. It's not Parkinson's. Remember, Parkinson's has the pill rolling, the shuffling gait, and the resting tremor. This is a benign essential tremor, so that's one way you can differentiate between Parkinson's and benign essential, which people don't really do. But if a patient comes in and say, I notice after I drink a beer or a glass of wine that the tremor kind of dies down or goes away, then you don't have to worry about Parkinson's usually. A concussion headache can last post 6 months if someone complains of lower back pain. Then check the SI joints. I also wrote a little note in here that said Klonopin, Clonidine, Clomid, because I had to make sure I'm telling the difference between each of them. And Klonopin is like a long-acting Xanax, and Clonidine is hypertension usage. You can also use it in menopause, and you take at night, and it helps with vasomotor, like sweats, night sweats. You want to keep albumin as a lab above 2.2 to reperfuse the kidney. Sundowning is the earliest sign of Alzheimer's, and Lyrica can also cause sundowning. So by sundowning, I mean, for example, we had a patient that came in and she kept thinking that bugs were crawling all over her, and it only happened at night after the sun went down. And my doctor explained that that's common. Next is Alzheimer's. She also was already very forgetful. Her daughter came in with her all the time, and we gave her Seroquel, which helps with sleeping and helps calm her down somewhat, and it worked. So that helped. Patients with Parkinson's can lose salt and water, so put on a mineral corticoid to help. It can lower the blood pressure. Let's see. Asbestos leads to mesothelioma, which we learned that. If somebody come in with a overdose on clonidine, use Narcan. That's one of the things I learned. Add 20 grams of potassium to IV fluids in normal saline drip in DKA, and 10 milligrams of phosphate. Give potassium whether it's high or not, because in DKA you usually are hypokalemic because of the glucose in the cells and all the pathophysiology that's behind that. But normally once DKA resolves, no, you're hyperkalemic, I'm sorry, excuse me, you're hyperkalemic in DKA, and usually after that resolves you're hypo. So you're being preventative by going ahead and putting the potassium and the phosphate in the IV fluids just to make sure that everything is right after it resolves, etc., etc. Yeah, because when DKA improves, your potassium is going to bottom out. Anytime BUN is out of proportion to your creatinine, it could mean that you have a GI bleed. Excuse me, y'all. I'm still trying to find out what points, because if y'all could see this, you would see I just wrote all over. I be writing on. Every time you be talking, I'd be like, oh my God, I gotta hurry up and get this done. So hold on. Okay, people with stroke cannot wrinkle forehead. People with Bell palsy can. HSV can cause Bell palsy too. P.T. Barnum loves all kids. I mean, he knows that. We was all taught that. Wellbutrin is a good depression medication. It increases dopamine in the brain. It can go well as an add-on for depression. You can use it for smoking cessation. Always do a chest x-ray and a urine analysis on sickle cell patients to make sure they're not infected. One of the most common infections sickle cell patients get is pneumococcal infections. Anytime they have a fever, anytime you see a sickle cell patient present with a fever, automatically admit, because you don't want to let them go home with a fever and you miss something, or they go into a crisis, etc. And Restorel 30 milligrams is a great start for sleep. I had plenty of more stuff, and I was so excited to share it all with you. As you can see, these are like little notes. At the end of my rotation, every day me and my doctor would go over things, and he also used to be a teacher at one of the medical universities, and his mother was a teacher, so he likes to somewhat teach. So 15 minutes at the end of every rotation, he would sit down with me and we would pick a topic to talk about, and he would give me all his little pearls. But I don't know if y'all heard the saying, doctors can't write, but I don't know what that says. So I'm so sorry. If I can make out any of it, I'll make a separate video, but I don't know what any of it is saying. So now that we're done with the clinical pearls, moving forward, I am planning on doing a video on mental health and a video on color in medicine. When I say mental health, so many of my classmates, and including me and other PA students that I interact with, have all had spells of depression, and we all do have ups and downs in life every now and then. But what becomes a red flag is when you can't halfway recover from it, so to speak. You feel down all the time. Y'all know the symptoms of major depressive disorder, and anxiety, of course, is through the roof in PA school, and we experience depression, and some people are put on certain medications. And I just want to have a YouTube video because I think that there isn't enough awareness about mental health, period, but especially in medical school and grad school and stuff like that. Not trying to scare anybody, but I feel like it needs to be talked about. So I don't know when, because I'm on rotations and I'm busy, but I have good intentions, and that's one of the things I want to do. And I also want to talk about color in medicine, and that's self-explanatory. So stay tuned. I thank you guys for tuning in. I thank you for supporting me. Thank you for all the inboxes I've been getting. If you have a topic that you want me to talk about, please feel free to comment down below and I will get back to you, or send me a message. Don't forget to follow me on social media, and as always, stay tuned for more End of Rotation reviews and my next reviews coming up in the next 5 weeks. My name is Reese. Thanks for following my journey. Bye.